Yes, we can start, Dr. Ihab.
Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It is my pleasure today to present cardiovascular complication of immune check inhibitors, what is abbreviated as ICIs, or cardiovascular immune-related adverse events, IRE adverse events. So I start with the introduction to my lecture. In 2018, the Nobel Prize in Medicine were given to two scientists who advances the discovery of immune therapy for cancer. Nobel Prize was given to the American James Allison and to the Japanese scientist Tasuku Honjo. They both won the Nobel Prize because they have discovered ways that we can improve cancer therapy by inhibiting negative immune regulation. It means that we can activate the immune system of the patient to attack the cancer cells. So, and also to give you an introduction, Bob Marley, who died in 1982 from metastatic melanoma, he was a very famous Jamaican musician, and he was delivering a lot of political messages. He dies because of metastatic melanoma, a disease that is nowadays is very much treatable with immune check inhibitors. So what are immune check inhibitors? Immune check inhibitors are a type of drug that blocks protein called checkpoints. These protein checkpoints are made by some types of immune system, such as T cells or killer T cells and some cancer cells. These checkpoints helps keep immune responses from being too strong and sometimes can keep T cells from killing cancer cells. So when these checkpoints are blocked, T cells can kill cancer cells better. So how many check proteins are found on T cells or cancer cells? We have different types of checkpoint proteins. They are abbreviated as BD1 and BDL1 and CTL4 and B71 and B72. So we have different types of checkpoint proteins found on T cells or cancer cells. They are named BD1, BDL1, and CTLA4, B71, and B72. And these checkpoints proteins, when they are blocked, the T cells can attack and kill cancer cells. In the next diagram, I am going to show you that those checkpoint protein inhibitors, when they get attached to the CTLA4 and B7, they can activate the T cells so that the T cells can attack and kill the tumor cells. In the next example, also another type of immune check inhibitor is attached to a protein called BDL1, and this protein, when it is inhibited, the T cells becomes activated and was ready to kill the cancer cells. So these are the immune check protein inhibitors, they block certain types of receptors on immune system and on tumor to attack the tumor cells. So how many checkpoint inhibitors we know? We have now very long list of immune check inhibitors, and they are all sharing the last 4 letters, UMAB. They are sharing the last 4 letters. Excuse me. So they are sharing the last 4 letters, UMAB. So they ends up with the word or with the letter UMAB. And it has been successful. Companies are producing a lot of immune check inhibitors. They all share the last 4 letters of UMAB. Why we as cardiologists or physicians are concerned with immune check inhibitors, which are new type of cancer therapy? It is important to know that oncologists believe that up to 1/3 of cancer patients may be eligible to get immune therapy at some point in their cancer therapy, especially metastatic cancer, and especially types of cancer like melanoma, which was the first example of cancer treated with immune check inhibitors. In 2019, there was more than 3,362 clinical trials initiated worldwide to evaluate the effectiveness of immune therapy in cancer therapy. So this was used either as single agents or combination of different immune check protein inhibitors. And it has been now recognized that those type of new cancer therapy, they can cause cardiotoxicity, and that is why we as cardiology are concerned. What is the history of immune therapy for cancer? Immune therapy for cancer has been started long time, maybe 200 years ago. Scientists were looking for ways to improve the immune system of the patient by using either viruses or bacteria or different types of any agents that can improve the immune system. This diagram I downloaded from the Society of the European Society of Cardiology, and it gives us a historical progression of the immune therapy. Scientists were really advocating to improve the immune system of the patient until our American scientist Jennifer Allison and the Japanese Honjo discovered ways to have the check proteins being blocked. And we have now different types of immune check protein inhibitors that they can be treated to treat prostate cancer and melanoma and other types of cancer. And we have 2 types now of immune therapy agents. They are called the ICIs and the CAR T cell therapies. Both of them, they share the same property of blocking certain protein on immune system or cancer cells, and they can make the immune system hyperactive and can recognize and kill the cancer therapy. The first agent that was used in 1996 to treat metastatic melanoma, a drug that was discovered by Bristol Myers in 1996, and eventually they got FDA approval. And this is the mechanism by which cancer therapy, the new cancer therapy, when they activate the immune system, they can make and they can cause adverse risk on the cardiovascular system. So what does the immune system therapy does? It causes increase in the CD8 T cells and in the CD4 T cells and the CD68 macrophages. All of these active immune system, they can cause adverse cardiovascular side effects like myocarditis, fulminant myocarditis, myocardial necrosis. Sometimes they can cause a Takotsubo-like syndrome. They can cause precardial disease. They can cause arrhythmia, and they can cause vascular injury. But alhamdulillah, fortunately enough, the risk of cardiovascular complication is less than 3%, as we will show in the next slide. Is the immune system therapy only toxic to the cardiovascular system? It can be toxic or have adverse events on any system of the body, like the neurological system, respiratory, renal, dermatological, but it is also toxic sometimes to the cardiovascular system. And the most important side effect is myocarditis. And myocarditis also, or other than myocarditis, they can cause conduction defects. They can cause Takotsubo-like syndrome. They can cause coronary artery disease, and they can cause pericarditis. So the spectrum of cardiovascular adverse events is so huge, and it can cause a lot of cardiovascular side effect, but still it is within the 4% or the 3% of the patient treated with the immune check inhibitors. So what are the epidemiology of immune check inhibitor associated cardiovascular diseases? From pre-marketing trials, we know that myocarditis occur in the ratio of 0.06% to 0.27%. So a very small number of patients was deemed to be subjected or was associated with adverse cardiovascular events. But the real data world and more clinical trials have confirmed a higher rate of myocarditis. It has been now shown that up to 1.4% of treated patients, and some people might say up to 1.7% for combination immune therapy, might be subjected for immune therapy adverse event on the cardiovascular system. And when there is combination therapy, there is more associated cardiovascular adverse events. So beyond myocarditis, other cardiovascular related adverse event could be precardial disease, acute coronary syndrome, thromboembolic phenomena, but they are again something between 3% to 5.8% for combination therapy. So all overall, it will not exceed 5% of those treated, and the risk will be higher with combination immune therapy. When will be the cardiovascular adverse event will be seen in the patient treated? It can be treated within the first 6 months, we can see the effect, the adverse event, or we can see the adverse event after 6 months. So we could have adverse event in the first 6 months, or we could have adverse event after the first 6 months of therapy. And these are important to consider whenever we have a patient who present with different types of cardiovascular symptoms and signs, chest pain, shortness of breath, or abnormal ECG, echo, cardiac MRI, and so on. Myocarditis is believed is the most important cardiovascular adverse event, and it has a prevalence of 1.7% with immune check inhibitor combination. But the problem with myocarditis adverse event, it can be associated with significant mortality of 25 to 50% of those treated with immune-related adverse events. This is different from the myocarditis from different other causes. It will have a mortality of only 4%. Remember, those are cancer patients, and they might be metastatic cancer, and they have already decreased survival, or they have multi-organ damage or multi-organ failure. When they are subjected to myocarditis, the mortality can reach up to 25 to 50% from immune-related inhibitor therapy. How to compare it to 4% of myocarditis from different causes. So according to the European Society of Cardiology, it is important whenever a patient who is treated with immune check inhibitor to look to the clinical factors associated with adverse events, like patients who have pre-existing cardiovascular disease, or patients who is getting immune check inhibitor combination, or a patient who present with heart failure or cardiogenic shock, or a patient who present with prolonged QRS on the ECG, or at least low voltage ECG on the QRS, and also patients who present with abnormal echo or cardiac MRI findings after starting immune check inhibitors, or patients who have positive protein biomarkers like troponin or BMB or endomyocardial biopsy. Very important to start high-dose steroid, and there should not be any delay in the management. And it is important to diagnose myocarditis from immune check inhibitors, either based on the clinical presentation or by finding a biopsy. Cardiac MRI can be of a lot of help, because sometimes the ECG and echo will not show the exact changes from myocarditis. According to the mechanism proposed by the European Society of Cardiology, patients who have adverse myocarditis from immune check inhibitors, they can have a very high mortality, and high-dose steroid should be started without delay. We will show you in this adverse events how the European Society of Cardiology proposed to treat myocarditis and other cardiovascular adverse events from immune check inhibitor related therapy. First of all, to stop the immune check inhibitor therapy, and second, to start the patient on high dose corticosteroid like 1 gram of methyl prednisolone intravenously for 3 days, and then followed by prednisolone 1.5 milligram per kg per day. For patients also with precardial disease or other form of cardiovascular adverse events, stopping the immune check inhibitors should be done. and steroid should be given to the patient. But for myocarditis, once myocarditis is confirmed or suspected from immune check inhibitors, consider stopping permanently immune check inhibitor therapy. What will happen if the patient did not improve with corticosteroid? The American College of Cardiology also proposed that after stopping the immune check inhibitor therapy, we can consider other types of immune therapy that can inhibit the immune system, like giving the patient mycophenolate mofetil, infliximab, and anti-thymocyte globulin. What this additional immune therapy will do, they will try to taper down the hyperactive killer T cells of the immune system so that they cannot attack the cardiovascular cells, and they can improve the patient condition. For precardial disease, other than also providing precardiocentesis and stopping immune check inhibitor therapy, steroids should be given, as well as colchicine and non-steroidal anti-inflammatory drugs, which are standard treatment for pericarditis. And for patients with Takotsubo and acute coronary syndrome, they should receive the treatment as was recommended in the guidelines. And that is conclusion of my lecture. And I am ready for any questions you would like to ask me.